Hello guys, welcome back, and in this video lecture we are going to talk about diabetes mellitus, which is one of the most common non-communicable disease across the world and in India. So India is considered as the diabetic capital of the world, and the reason is insulin resistance. So due to the presence of high level of glucose in the diabetes, it can cause complications like immediate complication or long-term complication. So diabetes mellitus is a disease in which there is high blood glucose level. So in the blood, according to compared to the normal glucose level, in diabetes there is high glucose present in the blood. If you see the pathophysiology of a diabetes mellitus patient, so what happens? The presence of insulin in the intestine. So first of all, sucrose is converted to glucose in the intestine. This is when we are talking about in the intestine. Sucrose is converted to glucose by alpha glucosidase enzyme, and this glucose gets absorbed and it reaches the liver. When it reaches the liver, it is stored as glycogen in the liver, and it will take up this glucose. The skeletal muscles and the adipose tissues will take up this glucose. So in the pancreas, when there is a blood high glucose level, in the pancreas we have beta cells present in the pancreas, and when the glucose is high, these beta cells releases insulin hormone. This insulin hormone act by inhibiting the ATP sensitive potassium channel. Also in the pancreas, we have amylin. So pancreas also secrete amylin. Amylin decreases the glucagon. Amylin also slow down the gastric emptying, and the satiety feeling. After you eat something, you feel that your stomach is full. This feeling of satiety is also felt. The meal ending satiety is also felt because of the amylin. So when the blood glucose is high, we see two things. One is release of insulin and another one is release of amylin. Another thing is, if glucose is high in the blood, it also comes in the urine. So what happens when glucose is high in the blood? There are chances that we get the glucose in the urine as well. So the glucose, when it is more than 180 milligram per deciliter, then it will come into the urine. Whenever the glucose comes by filtration, so it is coming in the urine, that means it is coming via the kidneys. So when the blood is filtered in the kidneys, here whenever the filtration happen, it will take up SGL2, which is the sodium glucose co-transporter 2 majorly, and also SGLT1. So if the glucose is taken orally, then it releases incretins, which is a glucagon-like peptide, GLP. Glucagon-like peptide, we also said GLP-1. So it causes increase in the insulin. So this release causes increase in the insulin, and this GLP-1 stimulates the satiety. It also decreases the glucagon level, and it also slow down the gastric emptying. These features are similar to that of the amylin features, like decreasing the glucagon or slow down the gastric emptying or the feeling of satiety, or the same feature as that of the amylin, which is secreted by the pancreas. And here we have this glucagon like peptide. So this glucagon like peptide decreases the glucagon level. This GLP-1 is inactivated by dipeptidyl peptase 4, which is DPP4. So glucose release is controlled by the brain also. The sympathetic nervous system increases the blood glucose level. So you see the increase in the glucose. Whenever there is increase in the glucose in the body, there is a release of insulin. Also, like amylin is released, or we can say because of the GLP-1 also there is decrease in the glucagon. So the ways to control diabetes is, first of all, you can give directly insulin to the patient. So giving insulin to the patient will decrease the glucose in the blood. And by giving the drugs that stimulates the amylin receptors, you can also give these drugs like pramlintide. So these drugs can be given, or you can give the drugs that are agonist to GLP-1. So you can give GLP-1 receptor agonist. You can also inhibit the glucose by conversion of sucrose to glucose in the intestine. So you can, by inhibiting the alpha glycosidase enzyme, you can inhibit the conversion of sucrose to glucose. That means less glucose is formed and less glucose is absorbed. Also, you can inhibit the absorption of the glucose. So these are the ways you can control the diabetes, and in this particular lecture we will be talking about these different ways, like first of all giving the drug insulin, or you can give the drugs that stimulate these amylin receptors. So since either you can give insulin, or you can give a drug that will stimulate this amylin receptors, or you can give GLP-1, which has the same function of that of amylin. You can give a GLP-1 receptor agonist. You can also inhibit the glucose, sucrose to glucose transformation. So by inhibiting the enzyme alpha glycosidase enzyme, you can inhibit the conversion to glucose. Also, you can inhibit the absorption of the glucose. So what is the diagnostic criteria? When do we say the individual is having diabetes mellitus? Very important, guys. So according to American Diabetic Association, the glycated hemoglobin, which is HbA1c, is more than or equal to 6.5%. See, this HbA1c test will tell about past 3 months of glucose, blood glucose. So from past 3 months, how is your blood glucose level? That is detected with the help of HbA1c test. So if it is more than or equal to 6.5%, we can say the person is having diabetic. Or if the fasting plasma glucose is more than or equal to 126 milligram per deciliter, or if the postprandial plasma glucose is after you had a meal after 2 hours, when you do a glucose test, that is a postprandial. If the value comes more than or equal to 200 milligram per deciliter, that means the person is having high glucose level in the blood, and we call this condition as diabetes mellitus. Or if you do a random blood glucose testing and the random test blood sugar comes out to be more than or equal to 200 milligram per deciliter, plus we have symptoms of hyperglycemia. So symptoms of hyperglycemia, you will say a patient, see, if in your clinic, 40 plus year old, suppose a 42 years old male guy comes to you and he says that he is having increased urination, that means he is having polyuria. Or if he says he's having increase in the thirst, he feels very thirsty, so it is polydipsia, and his appetite is increased, that is polyphagia. So all of these are the symptoms that tells us about the person is having hyperglycemia. And on investigation, you ask the individual to check the glucose level, and you see the fasting plasma glucose level of that individual is 180 mg per dl. So you see the fasting, what is the fasting level? If it is more than 126, we call this condition as the diabetes mellitus. And upon the urine examination also, you see a 2+ glucose level. So you tell this patient that the person is having diabetes mellitus type 2, because there is a high glucose in the circulation. Along with that, symptoms of hyperglycemia like polydipsia, polyphagia, polyuria. Now, another case of diabetes can be a 2-year-old child. Remember, if a 2-year-old child is brought to you by the mother, and after you do a routine examination, you find out that the child is having a high random sugar. Suppose if the child is having a random blood glucose of 300 mg per deciliter. So we know if it is more than 200, if the random blood sugar is anything equal to or more than equal to 200 milligram per deciliter, that means the person is having diabetes. Now this is a 2-year-old child. So this condition is a diabetes mellitus type 1 individual, which is inherited. So here there is insulin resistance. Now coming to a third scenario in which a pregnant lady comes to you with a postprandial blood sugar level of, say, suppose 250. Anything Anything above or equal to 200, we say it is diabetes. Since the patient is pregnant, so we call this condition as gestational diabetes mellitus. So you can categorize all these diabetes based on the condition. If the person is having since birth, or if the patient is having because of obesity, because of the lifestyle, then it is type 2 diabetes. Or if it is in pregnant lady, we call this a gestational diabetes. So all these things you have to see and then categorize based on the high blood sugar level. And we have talked about this criteria, in which if the HbA1c is more than or equal to 6.5 gram 6.5 percentage, or the random blood sugar is more than or equal to 126, or the postprandial and sorry, if the fasting, this is the fasting is more than or equal to 126, and random and postprandial, if it comes to be more than or equal to 200, we call this condition as diabetes mellitus. Now there are long-term complication and immediate complication. If the person is having immediate complication, it can be a diabetic ketosis, or the patient can have a long-term complication if the patient is not managing the blood sugar level, if the person is not taking the medication properly. So in that case, the person may develop a long-term complication such as retinopathy, nephropathy, or neuropathy. So it is very important to take the medicines on time. Now coming to ways to treat this diabetes mellitus. So we have talked about different ways to treat. For example, either you can give insulin to the patient, either giving this insulin to the patient, or giving the drugs that are going to stimulate the amylin receptors. So both of these act when there is high blood glucose level. Or if you give GLP-1 receptor agonist, or if you inhibit the glucose by inhibiting alpha glycosidase enzyme, or if you inhibit the absorption. So we will talk about one by one. The first thing that we are going to talk is giving insulin to the patient. How can we treat diabetes? By giving insulin to the patient. So first of all, understand the mechanism of action of insulin. Whenever there is a high glucose level in the blood, that is detected by the pancreas. So in the pancreas, we have beta cells. These beta cells releases hormone that is known as insulin. These insulin act on the receptor, which is tyrosine kinase receptor on the cell, TK cells. When these receptors, if this is a cell, when these receptors are activated, the tyrosine kinase receptors, they activate the immediate pathway. This activates the gene translation in the nucleus. And see, this activation of gene translation, for example, they can also increase the production of GLUTs. If they increase the production of glucose transporter, then glucose is taken inside the cell. So glucose that is present inside the blood, it comes inside the cell. That means there is less glucose in the blood now, because the glucose is coming to the cells. So more glucose in the cell and less glucose in the blood. So this is how insulin decreases the blood glucose level, by bringing the glucose from the blood to the cells. And this is the function of insulin. Now, since there is more of blood glucose in case of a diabetic patient, more of glucose is present in the blood. So we want this glucose to go from the blood into the cells. So we give insulin to the patient so that glucose enters the cell and there is less insulin in the blood. But along with that, what happens? There is also entry of potassium into the cells. So that means less potassium is present in the blood, and therefore the patient develops hypokalemia, because along with the glucose, this time there is also entry of potassium from the blood into the cells. So the person develops hypokalemia. What happens in the liver? See, in the liver, there is decrease in the glucose and increase in the glycogen. Glucose is stored in form of glycogen. So glucose is reduced. That means there is a less gluconeogenesis. That means less glucose is forming. Or there is increase in the glycogen synthesis. And also the breakdown of glycogen is reduced, because glycogen breaks to form glucose. And the function of insulin is to decrease the glucose. So therefore, there is less breakdown of glycogen, more synthesis of glycogen. So increase in the glycogen synthesis, decrease in the glycogen breakdown, that is glycogenolysis. And also decrease in the glucose synthesis. What happens in the skeletal muscles? So in the muscles, there is increase in the glucose uptake because glucose is coming from the blood into the muscles. So protein breakdown is also inhibited. In the adipose tissue, there is inhibition of the fat breakdown. So also there is increase in the glucose uptake in the adipose tissue, and this will inhibit the breakdown of the fat and leading to the weight gain. So this is the function of the insulin. This is how insulin acts. And can you give insulin orally? No, you cannot give insulin orally because insulin is an amino acid. So it is basically a protein. And if you give it orally, it will break down this protein, and therefore insulin is not given orally. Insulin is given as the injection forms. So in case, what is the pharmacokinetics? In case of a renal failure, you need to decrease the dose of the insulin. From where this insulin is coming? What is the source of the insulin? So it is either coming from the pork or it is coming from the beef, but in both the cases, the adverse effect of this insulin, which is coming from pork or beef, there is allergic reaction that can be seen in the person. So we have come up with a less allergic insulin, which is a monocomponent insulin, or which is a purified insulin. We have also come up with a recombinant DNA technology insulin that is known as human insulin. Also, we have analogs of insulin like Lispro or Aspart. These are the analogs of the insulin. So which all condition you give insulin? Of course, in case of type 1 diabetes, it is very important because insulin is the main treatment for type 1 diabetes mellitus. For type 2 also you can give insulin. For gestational also you can give insulin. And if you are shifting from oral drugs to insulin, if you can also shift. If the patient is in case of stress, or if the patient is having any infection, or if the patient is going for any surgery, in that case you can shift from oral to the oral drugs to the oral hypoglycemic drugs to the insulin. So these are the criteria in which you can give insulin to the patient. What is the emergency use of insulin? In which emergency case you give insulin? First of all, in case of diabetic ketoacidosis. As the name suggests, there is acidosis in the blood. So because of the high glucose level in the blood, the patient will undergo osmotic diuresis, and this will lead to acidosis. And as the name itself suggests, there is acidosis in the blood. So if the acid content is increased in the blood, that means you are going to give bicarbonates as the treatment. So in case of this acidosis, which is diabetic ketoacidosis, the treatment is you give a IV regular insulin. Also you give IV fluids. So fluids along with the insulin. And if the patient is having hypokalemia, you give potassium chloride. And to manage this acidosis component, you give bicarb to the patient. So sodium bicarbonate to the patient. Also, you can give antibiotics SOS. So another emergency use of insulin is in case of non-ketotic hyperosmolar diabetic coma. Particularly in case of type 2 diabetes, this kind of non-ketotic hyperosmolar diabetic coma is seen, and in that case, you give IV fluids, but you need less of insulin and less of potassium chloride in this case. And since there is no acidosis, so you don't have to give bicarb to the patient, sodium bicarb. The another emergency use of insulin is in case of hyperkalemia. See, in hyperkalemia, there is more of potassium, and we have already studied the function of insulin is it also takes potassium from the blood to the cells. Along with the glucose, it is also reducing the potassium from the blood, and it is taking into the cells. So basically we give hyperkalemia individual insulin treatment. So you can give salbutamol in form of nebulization, and insulin plus dextrose is given. Now, why do we add dextrose to the insulin in these individuals? Since the patient is non-diabetic. So along with the hyperkalemia, the patient will also have hypoglycemia because insulin will take glucose from the blood and take it into the cells along with the potassium. So there will be decrease in the blood glucose level. So the patient may have hypoglycemia. Therefore, we add dextrose to the insulin in case of hyperkalemia patient. These are the some functions of insulin. In all these situations, we can use insulin. Now talking about the adverse effect of insulin. So insulin causes hypoglycemia. Since it is taking glucose from the blood, taking into the cells, so in the blood there is less of glucose. So the patient may develop tremors or palpitations or sweating. So in diabetic patients, we do not give non-selective beta blockers because they can cause hypoglycemia unawareness. So the treatment if the patient is unconscious. Then we give IM glucagon and IV dextrose. And if the patient is conscious, so you can give glucon D or anything with glucose like sugar, you can give honey, you can give all these things you can give. If see, this is the one of the adverse effect of insulin, that is hypoglycemia, right? Hypoglycemia. Also, patient can have weight gain after the patient start with the insulin treatment, or patient can have hypokalemia also, because along with the blood glucose, the blood potassium level also decreases when you give insulin. So allergy is also seen with pork and beef and all these kind of insulin. Patient can also have mild edema because of the sodium retention. And lipodystrophy, that is because if you give insulin injection at only one site repeatedly, then the patient can have lipodystrophy also. What are the sites you can inject insulin? One is buttocks, another one is upper arm, and 2 inches away from umbilicus in the abdominal area, and also you can give lateral aspect of the thigh. Patient himself or herself can inject insulin. So insulin can be given as insulin syringes, insulin pens, pin pens are also available, and also continuous insulin pump devices are available. So this is about the insulin. Now let's recall the pathophysiology once again. So in the intestine, sucrose gets converted to glucose with the help of enzyme alpha glycosidase. Alpha glucosidase enzyme is the one that converts sucrose into glucose, and this glucose get absorbed and it reaches the liver and it is stored as the glycogen, right? Glycogen. This is glucose. Now, skeletal muscle, adipose tissue will take up this glucose, and in the pancreas, when this glucose is high, we have the beta cells in the pancreas. They secrete insulin when there is a high glucose, and this insulin inhibits ATP sensitive potassium channel, and therefore it decreases the glucose level. Apart from that, there is another hormone that is released that is known as amylin. Amylin is also released from the pancreas and it decreases the glucagon. It also slows down the gastric emptying, and also it gives us a meal ending satiety. That means the feeling of having a fulfilled meal, that our stomach is full. That feeling is that we get with the help of amylin. So if the glucose is high in the blood, then it also comes in the urine. More chances. If the glucose is more than 180, then it also comes in the urine. So whenever the glucose comes by filtration, then it will take up by SGL2, which is the major pathway, which is our sodium glucose co-transporter. If the glucose is taken orally, then it releases incretins, and these incretins are glucagon-like peptides. So GLP, glucagon-like peptide, GLP-1, and it also causes increase in the insulin. This GLP-1 causes increase in the insulin, and it causes decrease in the glucagon, and it also stimulates the satiety feeling, slow down the gastric emptying, similar to that of the amylin. So this GLP-1 is inactivated by DPP4, which is dipeptidyl peptidase 4. So this DPP4 inactivates the GLP-1, and the glucose release is also controlled by the brain, by the sympathetic system. So what are the ways to control diabetes? One way is the one that we have talked about, is give insulin to the patient, giving insulin to the patient. Another way that we'll be talking furthermore is the drugs that stimulate the amylin-like receptors. So we have a drug that is pramlintide. Pramlintide is a drug that stimulates the amylin receptors. We can also give GLP-1 receptor agonist. So the Drugs that act like GLP-1, we can also give GLP-1 is glucagon-like peptide, and since it increases the insulin, so it will decrease down the glucose, blood glucose level also. It will increase the insulin and decrease the glucagon. So this is the function of GLP-1. GLP-1 function, glucagon-like peptide function, is similar to that of the amylin. Another way is by inhibiting the conversion of sucrose to glucose by inhibiting this enzyme, which is known as alpha glucosidase enzyme. If sucrose is not getting converted to glucose, then the glucose is less in the blood. So you can also control the diabetes by inhibiting the glucosidase enzyme. You can also inhibit the glucose absorption. So that can also be done. So these are the drugs that we'll be talking about one by one. So the insulin we have already discussed. Now we'll be talking about amylin receptor agonist. Amylin, second is amylin receptor agonist. And in this category, the drug that we have is pramlintide. Pramlintide is a drug that is approved for both diabetes type 1 and type 2, and it decreases the glucagon. See, it acts on the amylin receptor, right? So it will function as same as that of the amylin. So it will decrease the glucagon, it stimulates the satiety, it also slow down the gastric emptying. Another one is giving the GLP-1 receptor agonist. So this function is similar to that of amylin. Again, it will decrease the glucagon, it will stimulate satiety and slow down the gastric emptying. So increasing the insulin release is the function of GLP-1. It is given subcutaneously and there is no hypoglycemia that is caused from the GLP-1 receptor. So we have the GLP-1 receptor agonist are the drugs that can be derived from human backbone, human GLP-1 backbone, or we have drugs that are derived from extendin 4 backbone. Extendin 4 backbone. So the drugs that are derived from human GLP-1 backbone are the drugs that end with glutide like liraglutide, LB-glutide, dulaglutide, or semaglutide. Dulaglutide is the one that is approved for the management of obesity, since it also decreases the weight. So weight loss again is caused by dulaglutide. So these are the human GLP-1 backbones. Extendin 4 backbones end with enatide, like exenatide or lisexenatide. So these are extendin 4 backbone derivatives. We also have GLP-2 receptor agonist. This is GLP-1 receptor agonist. GLP-2 receptor agonist are drugs like teduglutide. GLP-2 receptor agonist like teduglutide is approved for short bowel disease to slow down the gastric emptying. Now coming to oral anti-diabetic drugs. The drugs that we give orally in case of diabetes, and these drugs are mostly given for type 2 diabetes, wherein the cause is obesity, and because of the poor maintenance of the health, the person is having insulin resistance. So our function is to treat the type 2 diabetes by giving oral anti-diabetic drug, and we have 7 drugs in this category. The first one is biguanides. Biguanides are the drug, for example, metformin is a biguanide. Another one is thiazolidine diones, and we have pioglitazone in this category. The third is sulfonylureas. In sulfonylureas, we have 2 generations. Tolbutamide or glimepiride are examples for sulfonylureas. The fourth one is meglitinides. Meglitinides are the drug in which these are the drugs that end with glinides. For example, netglinide, ropaglinide. So these are the drugs that end with glinides. And as the name suggests, glytinides, they end with glenides. You can remember, they end with the glenides. Another one is alpha glucosidase inhibitors. Now, alpha glucosidase is an enzyme that converts sucrose to glucose, and if you inhibit this enzyme, then glucose is not converted from the sucrose. Another category is DPP4 inhibitors, and we know the function of dipeptidyl peptidase 4 is it inactivates the GLP-1. So if you inhibit this, GLP-1 will not be inhibited. Another one is SGL2 inhibitors. Now, this is sodium glucose cotransporter, and the function of this sodium glucose cotransporter is that it is going to reabsorb sodium and glucose back into the blood from the kidneys. Now, we do not want glucose to enter into the blood because already the patient is diabetic. So in that case, we give the inhibitors to SGLT so that glucose is excreted in the urine. So these are the drugs that ends with glyphosate, So let's talk about one by one. The first one is biguanides. So biguanides are the drugs, for example, metformin, fenformin. Fenformin is not used nowadays because it causes increase in the lactic acidosis, and therefore the drug that we use most commonly in this category is metformin. In fact, all of you must have heard about metformin drug. Now, the function of this metformin drug is that it stimulates the AMP kinase and it inhibits the gluconeogenesis. See, gluconeogenesis, as in the biochemistry we have studied, that means formation of the glucose. In gluconeogenesis, glucose is formed, and if you inhibit the further formation of the glucose, then we can control the diabetes. So one function is by inhibiting the gluconeogenesis by stimulating AMP kinase and hepatic glucose output. Another function of metformin is inhibiting the absorption of the glucose. So we are not letting the glucose absorbed. Another function of metformin, or it acts by increasing the glucose uptake, and this sensitizes the insulin. So therefore it is an insulin sensitizer, and this is used for the management of PCOD. So in case of PCOD patient, the female patient having the PCOD, we also give metformin to these individuals because it increases the glucose uptake, and therefore it is an insulin sensitizer. But the adverse effect of using metformin is, first of all, it causes GI upset. For example, it causes gastritis, or it can cause bloating. Or another one is it causes vitamin B12 deficiency, and therefore you must have seen the people who are taking metformin, we give vitamin B12, cobalamin to these individuals because eventually over a due course of time, they lack the vitamin B12, they get the deficiency of vitamin B12, and therefore we give vitamin B12 supplements to the individuals who are taking metformin. Another one is in case of renal failure. Now, whether should you use metformin or not in case of renal failure, if the GFR, which is normally 60, if it is 30 to 45 ml per minute, then in that case, you decrease the dose by 50%. If the GFR is less than 30, that means kidneys are not filtering properly. If it is less than 30 ml per minute, then you must stop the metformin. Also, if the serum creatinine level is more than 1.4 for females and more than 1.5 for males, in that case, you should stop the metformin. Stop the metformin. This is serum creatinine level. So this is biguanides, metformin. Another category of drug is thiazolidine, diones. The example in this category is pioglitazone. Pioglitazone drug act on PPAR gamma receptors, and they increase the insulin responsive gene in the adipose tissues, and therefore they increase the insulin sensitivity and they decrease the resistance to insulin. So by decreasing the insulin resistance, and by increasing the sensitivity to insulin, these drugs act. The third category is sulfonylureas. Sulfonylureas, we have two generations. First generation example is tolbutamide. And second generation example you must have heard of is glimepiride. Now, sulfonylureas, see, glucose enters into the beta cells of the pancreas. So glucose, when it enters into the beta cells of the pancreas, they releases ATP, they give ATP. This ATP act on the ATP sensitive potassium channel, and this puts the potassium out normally. But ATP blocks the ATP potassium channel due to the potassium stays inside and calcium enters into the cells. When more calcium enters into the cell, storing the insulin inside and releases the insulin outside, and therefore this drug also causes hypoglycemia. So this is the adverse effect of using this sulfonylureas. So this is how the sulfonylureas act by releasing the insulin by inhibiting the ATP sensitive potassium channel. And this is how the insulin actually works. So next category of drug is meglitinides. Meglitinides are the drugs, you can remember, that ends with glinides. These are the drugs that ends with glinides. So these are the drugs like netglitinide or repaglitinide. These are the drugs, and they act similar to that of sulfonylureas. Another category is alpha glucosidase inhibitors. Now, alpha glucosidase is the enzyme that converts sucrose to glucose, and if you inhibit this enzyme, no more glucose is formed. An example of alpha glucosidase inhibitors is acarbose. Now, if a patient is on insulin and he's taking acarbose, and if this patient comes to you and present you with an episode of hypoglycemia, now since the patient is taking diabetic drug, right, he is taking acarbose. So in that case, you cannot give table sugar in case of hypoglycemia. Now normally when the patient is in hypoglycemia, you give biscuits, or you just give sugar in the water, right? So you cannot give table sugar to these individuals as the first line of management. Why? Because table sugar is sucrose, and sucrose, which is inhibited by acarbose to convert into glucose because of this alpha glucosidase inhibitor action. So glucose, even if you give table salt to these individuals, no more glucose enters into the blood because this conversion is stopped by acarbose. So that is why you do not give table sugar to the patient who are taking acarbose as the insulin. In case of hypoglycemia, if this patient represents with episode of hypoglycemia, then you cannot give sugar to this individual because it won't work. Now coming to another category, which is a DPP4 inhibitors, dipeptidyl peptidase 4 inhibitors. So if glucose is taken orally, it releases incretin, which is similar to that of GLP, glucagon-like peptide. So glucagon-like peptide 1 functions causes increase in the insulin, and this function are similar to that of amylin, such as decreasing the glucagon, slow down the gastric emptying, or stimulates the feeling of satiety. So this DPP4, GLP-1 is inactivated by DPP4, which is dipeptidyl peptidase 4. But here we want to stimulate more of GLP-1 so that more insulin is released and the diabetes is controlled. So in that case, we give inhibitor to DPP4, which is dipeptidyl peptidase 4. And these are the drugs that end with the gliptin, for example, sitagliptin, alogliptin, or linagliptin. Now coming to the last category of oral anti-diabetic drug, which is SGLT inhibitor, 2 inhibitors. Majorly the absorption is via SGLT2. So this SGLT2, which is sodium glucose co-transporter, the function is it is going to reabsorb sodium and glucose back into the blood. When glucose is coming into the blood, the patient is going into hyperglycemic state, patient is going into diabetic state. So what do? You inhibit this transporter. If you inhibit this SGLT2 transporter, then glucose is not reabsorbed from the kidneys back into the blood. And therefore, this is how this SGLT2 inhibitor act, and these are the drugs that ends with glyphosate. For example, dapagliflozin, canagliflozin, these are the drugs that end with glyphosate. So SGLT2 inhibitors will lead to sodium and glucose loss into the urine. So it goes into the urine. So it also has got a diuretic effect. So it is beneficial in case of heart failure. It also causes weight loss. So these are the oral anti-diabetic drugs. These are the ways that you can control the diabetes mellitus by either giving insulin, or you can give the drugs, or we have drugs that stimulate the amylin receptors. So let's talk about again all of these drugs that we have discussed. So by first of all giving insulin, directly giving insulin to the patient, or the drugs that stimulate the amylin-like receptors. For example, pralinitide. So these are the drugs that increases the insulin, or you can say they decrease the glucagon, they stimulate the satiety feeling and slow down the gastric emptying. Or you can give GLP-1 receptor agonist. The function of GLP-1 is similar to that of amylin. So it increases the insulin, decreases the glucagon, similar action. Or you can inhibit the alpha glycosidase enzyme, because this enzyme converts sucrose into glucose, or you can also inhibit the glucose absorption. So all these drugs we have talked about in the management of diabetes mellitus. So very important topic, the management of diabetes mellitus, guys. This is about diabetes. All the best.